My next speaker is another international a speaker of international renown, Dr. Samuel Mehr. He's a nuclear medicine specialist, and he's currently practicing in Omaha, Nebraska. An interesting tidbit about Dr. Mehr is that Dr. Mehr was among the first physicians in the United States who established the Clinical Molecular Imaging Center, or commonly known as the PET scanner. And guess what? I was just a 1 year old toddler when he did that. So that goes on to show you his level of experience, expertise in the field. He has been an invited speaker globally in all the top tier meetings related to medical oncology, nuclear medicine, and radiation oncology. It's an absolute honor to have Dr. Mehr here, and he will today be talking about an up and coming field called theranostics, especially PRRT. Before I hand over the podium to Dr. Mehr, I'd like to emphasize the importance of PRRT. In the field of medical oncology, if I have to rank all the data from all the phase 3 registrational trials, the NETR1 data, which led to Lutathera approval, has to be among the top 3 best looking data, outcome data from a phase 3 trial in all solid cancers, including breast cancer, colon cancer, or any other solid cancer. That's how impactful the data was and led to the FDA approval of PRRT in the US. So I'm super excited to hear Dr. Meher's talk, and please give him a round of applause. Over to you, sir.
Good morning or good afternoon, depending upon where you are. I appreciate having the opportunity of coming here and speaking with you. I'm also pleased to be able to hear Eric Liu. Eric Liu is, there's none better. And I hope you listen carefully to what he said, because by having the aggressive surgical intervention that he recommended, it makes my job easier when I treat you with PRRT. I practice at Nebraska Cancer Specialists, one of the largest community oncology practices in the central Midwest. We have a robust staff of professionals, MDs, PhDs, a large research division with programs in phase 1 through phase 4 clinical trials. Phase 1 clinical trials are the very earliest clinical trials, the first time drugs are given to humans. We have a theranostics center devoted entirely to systemic radiation therapy, PRRT, and I'll explain what that means in a moment. And we've actually just made arrangements to place a second theranostics center in the state of Nebraska, about 150 miles west of Grand Island, west of Omaha in Grand Island, Nebraska, to serve the people in western Nebraska and north central Kansas. So we're going to talk about peptide receptor radionuclide therapy for neuroendocrine tumor patients. And I said that in one breath. And before we get into the substance of the talk, I want to briefly discuss some terminology. We're going to be talking about somatostatin receptors. They're the gatekeeper of the tumor that allows this wonderful therapeutic technology to get into the tumor. We're going to talk about diagnostic scans. We're going to talk about NetSpot, the widely available scan that shows exactly where the tumors are. We're going to be talking about a new diagnostic scan that also demonstrates where the tumor is, but may provide greater availability for certain patients who aren't around large centers. We're going to talk about Lutathera, which is the treatment modality for neuroendocrine tumors. We're going to talk about the beta particle, the subatomic particle that does all the tumor destroying, and will briefly allude to alpha particles, which is something that's down the road. We're going to talk about protecting the kidneys during therapy. We're going to talk about pharmacological adjuvants, or things that help. And we're going to talk about the concept of progression-free survival. Okay, so PRRT, the peptide, that's a chain of amino acids that binds to a tumor cell receptor. That's where the radioactive particle goes and gets into the tumor. The receptor is that part of the tumor that accepts the peptide, and radionuclide therapy is treatment with an internally administered radioactive drug. This is different than conventional radiation therapy, where an external beam of energy is projected through the patient. This treatment is administered systemically, and the tumors are killed by specific molecules that preferentially accumulate within those tumors. So, theranostics. Okay, we have a radionuclide, a radioactive particle. We have two particles that we could choose from for therapy. We'll be talking about beta particles for the most part. And we have a gamma emitter that can be used for diagnostics. So we take one of those two radionuclide particles and link it to a molecule. The molecule is bound and goes to the tumor within the cell. It's kind of like a Trojan horse. Let's keep the Trojan horse model in mind. So here we see, I'm starting on the left-hand side of the screen. We see a cancer cell expressing somatostatin receptors. Those are the dark blue arrowheads, and they're on the surface of the tumor cell. Well, along comes a radioactive particle that binds to the somatostatin receptor. It's bound to the surface cell, and like a Trojan horse, that binding is admitted into the internals of the cell. And when that radioactive particle gets inside the internals of the cell, it wreaks havoc with the tumor. Okay, so how do we know where the tumor is? Well, we do a PET CT scan applying the PET radioactive particle to the tumor. We can see in the middle of the liver there's a large red spot. That's tumor. So we've done several things by looking at the tumor through this lens. First, we've identified where the tumor is. Secondly, we know that it's going to concentrate the molecule. And thirdly, we know how much of that molecule will be concentrated within the tumor. Because we're going to use the same molecule to diagnose as to treat the tumor, we know that a lot of diagnostic activity within the tumor will translate to a lot of therapeutic activity. So, once that radioactive, in this case, beta particle gets into the tumor, what does it do? Well, the beta particle model is to the left of the screen, and you see that the beta particle disrupts one of the two strands of DNA within the tumor. If we were to use an alpha particle, which is a different radioactive particle, it would break both strands of the DNA. Breaking both strands of the DNA is called a lethal hit. That means, for all intents and purposes, when you break both strands of DNA, you've destroyed that tumor cell. It can't do any more activity and it can't reproduce. If we break one strand of the DNA, there's a possibility that the tumor could repair itself. Okay, so the goals of PRRT, they're simple. One is to concentrate the radioactive drug in tumors, because by concentrating it within the tumor, we can give a much higher dose of radiation than we could possibly dream of through other methods of radiation therapy. And the second goal of treatment is to prevent this beta particle, in this case, from getting to organs that we don't want irradiated. In the case of PRRT, it's the kidneys. Okay. So what have we done before PRRT? Well, we've used suppression with either octreotide or lanreotide. It's commonly, and it still is, the first choice of treatment for neuroendocrine tumors. It blocks somatostatin receptors on the tumor cell, inhibits tumor function. Because it puts the tumor to sleep in a hibernating mode, it inhibits tumor function. There is no known mechanism for actual tumor cell destruction with these two drugs. However, on anatomic imaging, we often see that tumors have somewhat decreased in size following this form of therapy. It's available in two forms: the long-acting form of the drug, which lasts about 4 weeks. And those of you taking this drug know that you have to come in and get that shot in your hip every 4 weeks, and a shorter acting form of the drug, which can be given in higher doses and lasts for up to 12 hours. Okay. So those two drugs are given in conjunction with PRRT to increase the effectiveness of PRRT. Most centers now, including my own, use suppression, those two drugs, during and following treatment with PRRT. At the time that you have PRRT, you'll also have a second IV in which lysine and arginine are administered. This is the second part of the goals of PRRT. This prevents the radioactivity from getting to places where we don't want it to go. In the case of neuroendocrine PRRT, these two drugs limit radiation exposure to the kidneys. This is a dotatate model. It conceptually shows the amino acid makeup of the molecule and how the chelator and the radioactive particle are attached. I thought it was kind of a pretty picture. That's why I'm showing it to you. Okay, so what's the timeline? All right, someone wants to have PRRT therapy. This is what happens. At week 0 or before treatment starts, we put our patients on 4 weeks of suppression. At the end of the 4th week, they would normally be ready for another administration of suppression. However, instead of giving them suppression, we give them treatment 1 of Lutathera. At week 8 or 4 weeks Following the initial treatment, we evaluate and give another dose of suppression, and we continue that same process through 4 weeks of therapy. We encourage patients to stay on suppression for at least 1 year. And in fact, the literature now demonstrates that patients generally benefit from a lifetime of suppression therapy. The patient is evaluated on an individualized basis for a full year following therapy. We look for breakthrough progression. We look at bone marrow recovery because the bone marrow is irradiated during this treatment. We do not get repeat PET scans during this first year following treatment unless there's a clinical reason to do it. And that clinical reason would be there are symptomatic and laboratory indications that the patient may be progressing. So our goal of Lutathera treatment is to convert a potentially fatal illness into a chronic condition which can be successfully managed to the extent that the patient can lead a long and productive life. In other words, when it's time, our goal is to have the patient die with this disease, not of this disease. And in many, many cases, it's been demonstrated that we're achieving that goal. So this is how we evaluate how successful the treatment is. The first one is how well does the patient feel? That's at the absolute top of the list. We do laboratory tests and imaging evaluations, and there are certain effects called abscopal effects. Abscopal means there are occasionally benefits derived from a therapy that weren't expected based on the mechanism of therapy. And as I said, we continue therapy evaluation for a full year. So here's the treatment protocol. Our standard treatment protocol starts at hour 0, where we give antiemetics before treatment starts. This is actually a throwback to the time when we weren't able to protect the kidneys with just 2 amino acids, and we had to use a full spectrum of amino acids, which caused a lot of nausea in patients. Since we've moved to the 2 amino acid protocol for kidney protection, nausea has not been a problem. As a matter of fact, greater than 90% of our patients get hungry during the treatment, and many of them have a snack or lunch while they're being treated. Renal protection amino acids are given for about 4 hours, both before, during, and after the Lutathera. 2 hours following the completion of this therapy, we ask the patient to wait, and we give them their dose of suppression at the same sitting. Some practices give it the next day. The literature demonstrates there's no real advantage of waiting that extra day, and it saves the patient another trip back to the practice for that administration of the suppressant agent. So what are the adverse side effects? Transient myelosuppression. That means temporarily your bone marrow's ability to replenish blood cells is limited, and that's something that we monitor. Myelodysplastic syndrome and leukemia are a possibility, but are a late finding that we see years after the initial therapy. The incidence of these serious side effects are slightly under 2%, or about the same as one would expect with most conventional chemotherapies. Renal toxicity is a potential adverse reaction, but by giving the kidney protective agent, we find that to be a rarity. There is potential liver toxicity in patients that are treated with highly advanced liver disease. And as Dr. Liu alluded to, there's the possibility of carcinoid crisis when we liberate large amounts of hormone through destruction of tumor cells. And we are prepared to treat that. During treatment, fatigue is common during treatment. Nearly all of our patients say that they feel more fatigued during treatment. Hair thinning is commonly reported. Now, that's different than the hair loss that we get with cytotoxic chemotherapy. Women tend to notice that their hair is thinning a bit. Most men don't notice it. And in our patients, that has been a reversible phenomenon. During the course of treatment, the patient is evaluated every 4 weeks. So they're evaluated at midpoints between treatments, where we look at their blood counts to see how their bone marrow is responding, blood chemistry, and of course, their physical status. Okay, so how well does it work? This is a slide from the NETTER-1 trial where they compared progression-free survival, or how well a patient does, and we'll dive a little bit deeper into the term progression-free survival, when we compare Lutathera with what we call best standard of care, or conventional therapy. As we can see from this graph, patients who received Lutathera had an 80% advantage, or 79% according to the slide, compared with patients who had best standard of care. Anyone who treats patients with cancer will acknowledge that this is an astounding response. And this is the reason we're so excited about it. So, progression-free survival, what does that mean? It means the patients were alive and their disease stopped progressing. Make no mistake, the natural history of neuroendocrine tumors is progression. And the most serious and life-threatening type of progression is when the liver loses its ability to function properly due to replacement by tumor. And patients who had the PRRT treatment that I just described enjoyed a progression-free survival advantage of nearly 80%. So, what's in the future? Well, it works once and the tumors start to come back. So if that happens with any type of chemotherapeutic agent, they would repeat the chemotherapy. So that's what we're beginning to do with Lutathera, retreatment. There are several different retreatment protocols, ranging from a single full retreatment course to intermittent smaller doses, perhaps in a lifelong setting. We're looking at combination therapy, using Lutathera with other drugs that fight cancer. If you recall, I said that the beta particle only breaks one strand of DNA, and therefore the cell has the ability to possibly repair itself. Well, there's a class of anti-cancer drugs called PARP, PARP inhibitors, which prevent damaged DNA from repairing itself. So that's on the horizon, as well as combinations with other therapies as well. And very shortly, those people living away from larger centers who aren't able to receive the diagnostic portion of the scan may be able to receive it closer to home due to a different diagnostic scan that uses copper instead of gallium. Make no mistake, the treatment component, the Lutathera component, is available everywhere because the drug is shipped directly to the provider from the manufacturer. But getting the diagnostic scan for some patients can be a bit more of a challenge. That concludes my portion of the talk, and Dr. Liu and I look forward to answering any questions you may have.